I can tell you that this collaboration between 3 different organizations, the McGill School of Nursing and the major teaching hospitals in the McGill system, our organizing committee, it was an easy decision to support this conference because not only was it going to help us to raise the awareness within the McGill nursing community about this really important area, but it was going to show directly how committed nursing is to being part of an interdisciplinary dialogue to move us towards more patient-centeredness, more patient engagement. All right, now to the session. Canada is undeniably a leader in many aspects of healthcare, but when it comes to health engagement, we still have a lot to learn. Organizations in other countries have vital information for us about how to provide patients with the tools and information they need to play a meaningful role in healthcare delivery and improvement. The UK, following health reforms that radically changed who's responsible and accountable for providing services, is now focused on integrating tools and measures into a system that makes sense to patients. Our next speaker, Ms. Ruth Thorlby from the Nuffield Trust, is working with Picker Institute Europe, the King's Fund, the International Foundation for Integrated Care and National Voices, to develop a survey tool to assess how well users of health and social services feel their care is being coordinated. Learning from this groundbreaking work will serve us well in the future when patient-centered care coordination becomes a real priority here in Canada in the next years. Let's welcome Ms. Thorlby.
Well, thank you very much, and I'm delighted to be here and thrilled to have been invited. I feel that we actually have a great deal to learn from you, and I was able to attend the sessions yesterday and heard a great deal of inspiring work that's going on, so I really think the learning flows both ways. I spoke yesterday a little bit about some of the work that's going on in other organisations in the NHS in England around patient engagement. Today I'm going to talk a little bit about some work that's very much work in progress for us, but it's designed to try and understand the patient experience, not in a hospital, not on discharge from the hospital particularly, not in the GP services, but about care out there in the community, and care that involves both health and social care. This is something that's become a priority in the UK at the moment, and we really are struggling to think of ways of measuring it. I'm going to give a little bit of background. I will have to explain a bit of background about why we're doing this and the way we are now. I'll share with you some learning from what we've done so far. We're probably about a third of the way through, but nevertheless we have some insights and some interesting things have come out of it. And then some reflections really on what it's like and what the challenges are if you do really want to measure what patients can, and users and families can tell you about the extent to which care is directed effectively at them in the community. So this is Jeremy Hunt, our Secretary of State for Health. Now, he talks about integration a lot now and has done for the last 2 years. This is a very interesting quote from my point of view because I think he's right. In integration, what he means by that is that something that will happen better than it does now between health and social care is a defining challenge for our times in the way that waiting times were a decade ago. The Labour government, when it came in 1997, priority number 1 was to solve long waiting times in the NHS. Now we're in a different place, and actually what is probably keeping Jeremy Hunt awake at night and a lot of other policymakers is our rise in emergency admissions to hospital. We've had a 47% increase over the last 15 years. Last year, over 5 million people were admitted as emergencies to hospitals in England. A good proportion of these, we don't know exactly, but a good proportion of these possibly could have been prevented through better upstream care of some kind between organisations. But that is what is the problem, and in a way it frames some of the issues around measurement, that the outcome that is really needed is to flatten and possibly bend the curve in the rise in hospital admissions. This problem is not unique to us, as you well know. I've just talked about the word integration, and the title of my presentation is about coordinated care. This is already starting to get a bit confusing. we've used the word coordinated care because National Voices, which is a coalition of over 140 health and social care charities, voluntary sector organisations that involve users and patients, were asked to think of a way of explaining integration, and they immediately threw it out. They said this word means nothing to most people. Integration is a sort of non-word. They redefined it immediately as integrated care means person-centred, coordinated care. So what we're talking about really is person-centred coordinated care that involves better working together of health and social care. So a little bit of background so for you to understand what the unique problems that we're dealing with in England at the moment. Many of you, of course, are aware that the NHS, set up in 1948, is a free, at the point of use, universal service paid for by general taxation. There are user charges for prescription drugs, but they're very low. They're about £8 at the moment, and about 70 or 80% of people don't pay them. They are exempt. So there are very little out-of-pocket contributions for healthcare. It's pretty much free. Social care was also reformed in 1948, but it wasn't merged. So what we have are two different systems. Social care is organised through local government. It does have money from central government, but the crucial difference is that it's means tested. This is a ration service. Publicly funded social care is not available to everyone. So already we've got these two different structures. And making the NHS work more closely with social care, but given that the work overlaps, and from a user perspective, people don't always distinguish between who's a care worker and who's a healthcare worker. They don't really understand. We've been trying to do this for a long time, and we have some great examples where people have brought their budgets together and say, look, let's just forget these differences. We'll work together, and they've had good outcomes. So Thorlby, which is an area in southwest England, has been doing this for a while and has had some good results in terms of being able to invest in some preventative social care for people that seems to be able to reduce some of their hospital admissions. These examples are unusual. And so when the current government, coalition government, came into power in 2010, integration was one of the targets that they'd set themselves to try and do something about. Just by way of explaining what our current system looks like, this is something called a web of care, and it's quite a nice way of demonstrating graphically from a user perspective just how complex our system is. Yours will probably be similarly complex. But the boxes in pink represent social care. And in this, I'm not sure in this instance, Malcolm and Barbara. Malcolm has Alzheimer's, Barbara's his carer. They're using live-in carers, which is quite a high-cost thing. I would guess perhaps in this instance, these people are receiving publicly funded social care, but thousands and thousands of people have to pay for this themselves, and we don't really know the quality of that care, and we don't know the extent to which the people delivering that social care are talking to people in the NHS. That's before you think about all the people in the blue boxes, the GP, the district nurses, the dietitians, the dentists, the physiotherapists. These are all employed by separate organisations. And I remember vividly that the GP and the district nurses, in the case of my parents last year, didn't like talking to each other. So that was actually a really basic division. These were two key groups of people who did need to talk to each other. So this just illustrates how difficult this is, and also it illustrates that the only people who know how well these services are working together are Malcolm and Barbara in the middle. They're the only people who can really tell you that. So back a little bit more to the context for us. So when the coalition government came in, they published these very radical reforms to the NHS in England, and there was an outcry for various reasons, not least because the consultation process had not been done properly. And there was a pause in the legislation. And this hasn't happened before in legislation, and the government had decided that things were not looking good. There was a bit of a rebellion taking place amongst all the professional bodies in particular. And so they brought people together, and one of the findings of it was a group led by a GP, Steve Field, consulted widely. And one of the findings that came out of this is that we needed more integration. There needed to be a bigger focus and thinking about integration as a result of this. One of the motivations for this was that the coalition government had also placed a great deal of impetus on competition, market forces as driving quality. And this is unpopular and sensitive area amongst many people in the public, but also working for the NHS. So integration was already starting to have a different kind of meaning as something that wasn't competition. Competition, people argued, leads to fragmentation. People compete, they don't communicate. So integration was already a way of thinking about something good that wasn't competition, so confusing. Anyway, in 2012, the arguments are resolved, the Act was passed. There are now duties to promote something called integration across lots of different bodies in the NHS, including the regulator. In the process of this revision to the Act, National Voices, this coalition of charities, was sent to go and think of a common definition of integration, because it became clear from our work and the work of many others that there were so many different definitions. They came up with 175 different definitions of integration, coordination. It's just kind of word soup. And this is what they came up with, which has been interesting and a way of framing what integration might mean from a user perspective. What they did was they went back and consulted their stakeholders, and they thought they would define integration from the perspective of the user, which was, what would integration feel like and look like? What would you be able to say about your care if it was fully integrated? So you'll see here that the sentence, the kind of core sentence is, my care is planned with people who work together to understand me and my care, put me in control, coordinate and deliver services to achieve my best outcomes. And there are a series of statements, sentences, which are now known as I statements, under these different headings, different domains. So there's my goals, my outcomes, communication, information, decision-making, care planning, transitions, and emergencies. And these are known as the I statements. And it was very much a sort of, let's define this and just cut away all these other definitions. This is the definition that we are working with in England, and as a team, we thought we would perhaps start with to build on. So just to give you an idea what the I statements look like, this is one about communication. So if your care was well coordinated, you would be able to say, I was always kept informed about what the next steps would be. The professionals involved with me talked to each other. I could see that they worked as a team. I always knew who was the main person in charge of my care. I had one first point of contact. They understood me and my condition. I could go to them with questions at any time. And that person helped me to get other services and help and to put everything together. But as you can see, some of these are starting to be slightly problematic to measure, in the sense of the professionals talk to each other. How do you know they talk to each other if you're a patient? You probably only know if things go wrong. And there are a great deal of surveys, as we discovered when we started to do our background work on this, which are trying to get at some of this, or the symptoms of failures of communication. So the immediate context of our project was that as the 2012 Act bedded in, the government accelerated progress on integrated projects. So this is health and social care working together with some extra impetus. So they chose 14 pioneer areas, so these areas right across England, who've been given assistance and leadership development and other tools to try and help them accelerate their own integrated care projects. Typically these are older, frailer people, but there are also younger people with severe mental health problems, all the people who we know fall through the net of normal disintegrated care. More recently, there's been a large fund put together. It's not new money, but it's called the Better Care Fund. It's worth £3.8 billion, which is about 3% of the NHS budget. This is accessible to areas across England for health and social care projects. Now, what's interesting about this is that both of these, but particularly the Better Care Fund, are using, at the moment, to measure success, they're using proxy indicators. So they want to see that emergency admissions drop. They want to see length of stay come down. They want to see that people's delayed discharges from hospital are reduced in numbers. They have said they want a user experience of integration in this, but they've not been able to develop one because, for various reasons, because this is hard and there has been limited amounts of money to come up at the centre with it was hard to justify spending millions of pounds developing a completely new questionnaire, and a decision was made to try and come up with questions that could go in. We have a national survey programme for inpatients, for outpatients, for GPs, so the decision was made to try and develop questions that would sit within these other surveys, and that between all of them you'd be able to pull them together. Work is still going on there and it's problematic. I'll come back to why that might have been. So this was the context for our project. We decided that we would want to aim something at quality improvement efforts. Some of the stakeholder work we did prior to this, we heard quite strongly from people working in local government and local NHS services that they didn't want a tool that was just going to be used for performance management, just to sort of say, have you done this or not? They wanted something that might help them improve services locally. We're working with colleagues. National Voice is particularly important, but Picky Europe, who are doing all the technical work on survey development, the International Foundation of Integrated Care, which is Nick Goodwin's, who's a colleague from the King's Fund, set up an international foundation that's specifically looking at integrated care projects and is a good place to look for resources, and the King's Fund, of course, who've done a pioneering amount of work to promote integration and networks of local areas who are doing it. It's funded by the Aetna Foundation based in the US. It's going to finish, we hope, next July. My view is that we'll produce something that's a first step, really, at this point. I don't think it's going to be something that is necessarily going to be the only thing that's available. I'm hoping that other things will be developed, that we will be able to refine it over time, and our ambition is hopefully to produce something that might be able to work in other settings. We had to contain it. We decided not to go for integrated care for everyone. We decided to look at people over the age of 65 with at least one chronic condition. That's still quite a wide pool. I've alluded to the fact we did do some legwork. We've set up an expert advisor group, and I'm thrilled to say that Lena Cuthbertson, who's hiding over there, is one of our expert advisors from Canada, who's been extremely helpful to us in bringing some of the learning. We've done a literature review. We've looked through a great deal of surveys that have been developed internationally, and there are a lot of them that look at coordinated care, continuity of care, particularly around the transition from hospital to the community. And so we are building on the work of others, but we did want to root our work in the work that National Voices had already done. We've done focus groups with users, and I'll talk in a minute about the latest refinement of the I statements from National Voices, as they've done it for older people, based on in-depth interviews with 75 older people. We're in the process of cognitively testing a draft questionnaire at the moment, and our hope is that once we've completed that, we'll be piloting this questionnaire with about 3,000 older people in areas in England that will be distributed. This will be a paper survey that goes into people's homes, and it asks them about all aspects of their care, health and social care. So what we've learned so far from the process of developing this has been really interesting, in that it was almost impossible for us not to get tripped up by language here, and we were pulled up rightly, I think, by our expert advisory group, saying you need to be more specific about what these different terms mean. And it's been really hard, and there have been moments where I just feel like getting under the desk and hiding, because there is so much work done on this. So there are so many carefully crafted definitions and concepts out there, and yet we want to have a survey that was understood by people who use services. I think one of the papers that's been helpful to us is from Jeannie Haggerty, another eminent Canadian academic, who talks about that continuity can have these different dimensions. It can be do with the relations with people, management continuity behind the scenes, the continuity of information. We also very much wanted to understand the way the care happened at the key points. So all the normal care that happens at home, and then there are the planned transitions. If you have to go for an inpatient stay, then there's the emergency care. What happens if something goes wrong? Do you know who to call? I think for me, one of the most interesting debates has come out of the work was how we ought to start this whole survey. Now, National Voices felt very strongly that the work that they had done with older people, this is an example of something that will be published in the next few months. These statements for older people are about themselves and what they can do. It's about their own sense of well-being. I am recognised for what I can do rather than for making assumptions about what I cannot. I am supported to be independent. What they found from interviewing these older people, first of all, they didn't want to be called frail. They hate that term. Just don't call us frail. We know we're not going to be cured of old age, but we want you to think in terms of what we can do. and how independent and what social contact we can do. So we decided that we would start our questionnaire with these general questions about what's important to people. We've had quite a lot of pushback from colleagues who are saying, look, this is for service improvement. How is it going to be helpful for a GP to know whether someone's socially isolated or not? Surely that can't be helpful. But actually, we think, having talked to a number of stakeholders now, that this information sends a powerful signal straight away to the people who are filling it in, that this is about you and your outcomes that matter to you, and that actually some of our health and social care providers have said, yes, actually it's quite useful for us to know this information, to what extent people do feel isolated or unable to do things in their own home. So maybe these outcomes do matter. I was, just as a matter of context, in social care, and it may be the same here, social care has traditionally always measured people's well-being and their outcomes. That's much more of a sort of capabilities focus on it. In health, we measure how many times you go to the doctor and whether you recovered from that specific illness. This is a bit of an alien concept for people in health. So we now have 39 questions. It may be slightly too many. We start with health and well-being. We also look at your health day-to-day. We ask whether people get support from social services. We also ask whether people pay for their own social care, because we know a lot of people do. That question is proving reasonably well received in the cognitive testing, planned care and so forth. And we also ask the standard questions that go on all the other questionnaires to pick up the key points about age, gender and basic health status. So a couple of examples from the cognitive testing. This is a question about health and care staff bring together services that help me to achieve the outcomes important to me. We found this tested quite well. People understood this, partly perhaps because we had covered the outcomes to begin with. One person has said coordinating the left hand knows what the right is doing, what should happen in an ideal world. Quite often the person treating you doesn't know what's going on. A doesn't know B, B doesn't know, and C doesn't care. So people seem to understand what this question meant. But this one, which is sort of so important really, we're asking about, in the past year, has there been a time when health and care staff failed to share important information about your medical history or care, such as test results, with each other? This is a problem because people don't know unless something's gone wrong. And this is one, and we may have to have a rethink here. You wouldn't know this happened until you find out later when something happened or has gone wrong. So this is proving difficult, and it's also proving difficult for colleagues who are trying to test it in the other ones. There is one aspect of our particular context that's worrying me. This is someone who also talks a lot about integration. He calls it whole person care. This is Andy Burnham, the Shadow Secretary of State for Health, the Labour Party. A great deal of talk about integration, the need for it. He's talking about bringing social care in. Their vision is to bring the two budgets together. They say it's the key to unlocking the money. The big problem that we've got at the moment is that social care is so heavily rationed. It's got worse over the last 2 years. It's dramatically worse. One of the things that's really worrying me is not so much that the care isn't coordinated between health and social care. There just isn't enough social care. And we need to think quite hard about what that might mean, and that people are managing on their own. Somehow their carers are just managing, but this is a bit of an elephant in the room. So some concluding thoughts, a couple of slides and then I'm done. So rising hospital admissions is definitely the top of everyone's agenda. And there are a lot of integration policies that aim to do it. Now, we've evaluated over 30 different community interventions that aim to reduce emergency hospital admissions. These are things like community matrons, virtual wards, and so forth. Very few of them work. And in some cases, admissions go up. And we're not quite sure why that's happening. The whole logic behind the government's policy and integration is if you get care coordination right, get some more social care in place, you'll be able to reduce admissions. We're not sure about this. We're not quite sure what's driving this, which is why there is a real concern and anxiety on my part that some of these projects might be doomed to fail if we haven't been able to capture how important some of these efforts have been for users. So it's really, really important that some of these are shown to be this has made people's lives a bit more livable. It didn't necessarily prevent a hospital admission, but they were still worth doing for whole person care. Just to give you a final thought to go with, some of you saw this slide yesterday. I think this has come from Northumbria, which you heard about earlier. This was a quote that particularly struck me about how hard this work is if NHS and social care staff really start to step into this whole person care. This is somebody reflecting on what happened when they were trying to improve their critical illness rehabilitation. And they talked about the fact that when they brought patients back 3 years afterwards, how distressed they were. Our patients had relationships that had completely broken down, jobs that they had lost, and financial hardships. We had patients that came back to the clinic and just cried. It was heart-wrenching. What we're seeing with integrated care is GPs and people working in primary care stepping into this space. They're stepping into the real lives of people. This is hard. There's an example from Greenwich, which is one of the pioneer projects. They talk about a lady who's 52, who's been in and out of A&E. She's got an alcohol problem. When they sat down with her and said, what are your priorities, you as an individual? She said, number one, I want a job or some voluntary sector work. Number two, I want to lose weight and feel better about myself. Number three, I want my alcohol problem to be dealt with. So the GP has to, if whole person care is a reality, you have to be able to deal with 1 and 2 effectively, on the spot, before you'll get to 3. Otherwise, this is not the case. So there are lots of people moving into this. It's hard for them. My worry is that if we can't prevent the admissions, if we can't show these projects have worked in this very crude quantitative sense of bringing admissions down, it will be regarded as a failure, which I would hope doesn't happen. But if whole person care can be delivered, it's valuable just for having improved that person's life. Thank you.